Peter is a consultant at St George's in London, and he's also part-time in specialist private practice. He last spoke to this group nearly 15 years ago, also in English, I think. He's a farmer's son, and a very pragmatic and practical approach, and I can't think of anyone better to give us whether we should go for implants or endodontics. I'm sure he won't be shy in telling us his views. Thank you, Peter.
Thank you. Right. Good morning. Timing-wise, I mean, when we want to stop, just tell me we'll stop. Okay. Well, okay. I'm hungry too, though. Right. Thank you for the invitation. I know Ken's gone, very, very good, but thank him very much for inviting me. I'd like to. These are the issues we're going to discuss. It's going to be a cine show, okay? So that's how it's going to go. I'm going to start off with patient-centred outcomes. That's where we're going in terms of research, evidence, funding, etc. What do patients think of our treatments? Not what we think, what do patients think? And if you fit an implant-supported restoration in a patient, we may think, great, the occlusion's fine, this, you know, but what do patients think? And I've been asked here to talk about the difference between an implant-supported restoration versus a tooth that is restored that's been root treated. And if you look at the evidence is quite clear. Okay, OHIPS. Now, the OHIPS score is the score of negativity. So the lower the score, the better the patient likes it. It confused me for 2 years before I understood that, and I've just passed that on to all of you. And the OHIPS scores are very similar for fixed teeth, whether they're supported by a piece of titanium or whether they're supported by a dentine root. Very straightforward. So in your hands, the patient will be as happy or unhappy, depending on the patient, in relationship to your restoration, whether it's an implant or whether it is a tooth that is restoring the restoration and supporting the restorations. The other things, in terms of implants versus teeth, there's one other area I think is important, overdentures. We've just been hearing things about overdentures. We do not need to be helping ourselves to natural teeth if we can, because if we look at the difference between an implant-supported overdenture versus a natural tooth-retained overdenture, the OHIP scores are about the same. So again, with the overdenture situations, if you've got natural teeth, I applaud what's just been said, you want to try and keep them. Now, if we're talking about fixed implants, is a balance, and particularly at the front of the mouth, it's a balance, because you're putting titanium in where bone is and where teeth used to be, so you're not putting it in the same situation. And we all know that lip line's important, and the great news for lip line is as we get older, we show more of a lower teeth. It's a part of the male ageing process. We all go south, and males particularly start showing a lot more of their teeth in middle to older age, so that's great news. It means that we haven't got the high aesthetic issues. Women, unfortunately, show much more of their front teeth, and men are much more likely to have disguise of the central incisor teeth. Now, this is a lady, a very nice lady, who has a terrible muscular problem, and she fell at home, and she lost her front teeth. And she had a nicely made denture, which basically, one night when she was asleep, dislodged from her mouth and nearly killed her because they couldn't get it out of her trachea. And she ended up at St George's and everything, all kicked. And we set off funding for this patient in terms of this. We thought this was an exceptional clinical problem. She was a nightmare to treat, lovely lady, and very disabled. And I just want to show you this lady, because this lady basically had a denture that looked a lot better than these implants. We have the sound? Sound? Sound and honour? Any sound?
Things good?
Well, yes, thank you.
Good.
Yes,
Better
yes.
than the dentures, are they?
Oh, God. They're not, no comparison.
Now, remember that. This lady is a lady that was a tough character. She's got a tough disability. She's strong physically, and she's strong mentally. For her, the change from a denture to a tooth, a denture to an implant-supported restoration for her was very, very, very important. It was a life-saving change for her, potentially. But aesthetically, you saw her there. She had the classic, you know, high lip line of nightmare. But if you look at the literature on how much difference there needs to be between the gingival heights of teeth in comparison to the neighbouring teeth, for patients to see a difference, you're up to 2.5 millimetres. So it's really what you were saying yesterday. How good do these things have to be aesthetically, and how perfect? And I think the answer is probably not that much, to be honest. I think we can get away with a lot. Right, dentist decision-making affected by experience and formal training. Is it an issue? Let's go to Hong Kong, 2014. They looked at 3 types of dentists. They looked at GPs, putting implants in with no formal implant training, GPs that were under training in Hong Kong, and GPs that had done a formal training program in Hong Kong. And they gave them 9 scenarios of different scenarios of teeth, restorability, training, etc., and asked them what they would do. There was differences, big differences. Conclusion, in Hong Kong, I've never worked in Hong Kong, I don't know how the health system works there, but in Hong Kong, dentists who were under training or trained in implantology opted not to rehabilitate as often compared to Hong Kong GPs that had no formal training. 3 times as likely that the GPs with training or under training to retain compromised maxillary molars, particularly, with or without pain in comparison to GPs without any formal training. GPs who place implants in practice without formal training prescribed many more implants. Less other options were explained to or suggested to the patients to restore a space than GPs that have under training or have had formal implant training. And GDPs were less likely to root treat teeth and were more likely to suggest treatment options where outcome were not necessarily robustly supported by evidence. So the training in terms of implant training will play a part in decision-making in terms of whether you choose to retreat a tooth, preserve it, or whether you're choosing to remove a tooth. We can go